So our next speaker is going to talk about the things you don't see. So Dr. Joohi Jimenez-Shahed is Associate Professor of Neurology at Baylor College of Medicine. She is the Director of the Deep Brain Stimulation Program and Associate Director of the Neurology Residency Program. Dr. Jimenez-Shahed serves as co-chair of the Functional Neurosurgical Working Group of the Parkinson Study Group. She's also an investigator with the Huntington Study Group, Clinical Research Consortium for Spinocerebellar Ataxia, Dystonia Coalition, and the TSA International Database of DBS Studies in Tourette's Syndrome. She serves on the Science Advisory Board of the Davis-Finney Foundation, the Medical Advisory Board of the Tourette Association of America, and is the chair of the HAPS Medical Advisory Board, the most important one there. Thank you, Dr. Shahed. And she also serves on many other boards that you can see in her biography, and is also the recipient of the HAPS Roy H. Cullen Quality of Life Award, the Baylor College of Medicine Rising Star Clinician Award, and the Fulbright and Jaworski LLP Faculty Excellence Award in Teaching and Evaluation at Baylor College of Medicine. Please welcome Dr. Shahed.
Pamela, thank you very much for that lengthy introduction. I appreciate it. But I'm happy to be here. I think one of the most rewarding things that I do is the work that I do for HAPS. So I think it's fantastic that you all are here learning about this disease and how to help your loved ones live with it. I think one of the things that we definitely realize is that Parkinson's affects the entire family. And so it's important that you're here to kind of educate yourselves and understand how we can help our patients who are suffering from this disease as well. So the title of my talk is The Things You Don't See. And I know that sounds maybe just a little scary. I put the scary eyes on there. I was a little hesitant to put that. But I thought at least if it adds a little levity to the conversation, then it might be okay. So what we're going to talk about really are, okay, so now I need to use the clicker, and I'm going to be similarly challenged here. Okay, all right, so we're going to talk about hallucinations and things of that nature that patients are experiencing, but we clearly are not having that same experience. And so this can be very distressing, not only to patients, but then also to the caregivers. Everybody's sort of wondering what's going on, what's causing this. Does it mean, this person is losing their mind? I mean, what exactly is, the root cause, and how do we manage it? And I think part of the issue is that this can really create difficulties with care. Somebody was asking earlier about some of the mood changes and the behavior changes that can occur in Parkinson's, especially with the cognitive dysfunction. And this is one of those things that really I have seen in the patients that I have followed that can cause a lot of stress and distress between patient and caregiver. And so I want to be sure to maybe try to give some explanation to some of these issues and hopefully some strategies to help manage them. So these are some of the risk factors that are associated with development of hallucinations, and we'll do definitions in a minute and kind of really pick apart what these issues are. But people who have dementia, like Dr. York was talking about, hallucinations can be part of that symptom complex. And so if somebody is diagnosed with a cognitive impairment or dementia, the risk of developing hallucinations is higher. Individuals who have depression may also be more likely to experience hallucinations, and this is sometimes hard to tease out because there are patients who, if they have a very severe form of depression, can actually hallucinate only because of the depression and not necessarily because of any other things that are going on. So it can be very intermingled and sometimes a little difficult to tease out. People who have impaired vision may also be more likely to hallucinate. People who are older, people who have more advanced Parkinson's disease, and as now you're starting to see some of these things really kind of intermingle and go together, because we also talked about the longer you have Parkinson's or the older you are with Parkinson's, the more likely you are to have dementia. So you can kind of see how they kind of travel together. And then lastly, the Parkinson's medications that people are taking can certainly be risk factors, whether or not they have an underlying cognitive disturbance. Okay, so sometimes the medications themselves can be the cause of the hallucinations. But, it's not always the case that hallucinations mean kind of big and bad things. Okay, so Parkinson's drugs are designed to stimulate dopamine because we know that that is the thing that's missing in the brains of individuals with Parkinson's. They're losing the cells that make that dopamine. Now, dopamine is very important for movement, which is why if you don't have enough, then you get slow, you get stiff, you get shaky, you don't walk very well. But it's also important for other brain functions. And one of those is in the front part of the brain, what we call the frontal lobes. And that is where a lot of this cognitive function that Dr. York was talking about resides, and why those areas of the brain can also start having problems when Parkinson's is present. And it is known that when you block dopamine, so if you have, for example, a patient with a psychiatric disease such as schizophrenia, or maybe somebody with bipolar mania or something like that, and you need to use an antipsychotic medication, the reason those antipsychotic medications work is because they're blocking dopamine. Okay? They're just doing it in sort of a different brain structure that's not intended to be the one that is related to the movement. So dopamine is this complex thing. You need to have it in Parkinson's in order to move well, but at the same time it can really aggravate the situation if hallucinations are present, or could even provoke hallucinations in some individuals. So there are certainly patients who don't have cognitive impairment that may have purely drug-induced hallucinations, and that's why I kind of draw it back just a little bit to say that not all hallucinations are indicators of something big and bad, but it is important to kind of look and see what situation is present and to identify it correctly and then approach it correctly. So when people think about kind of psychosis, okay, psychosis is sort of a general term, kind of a lumping together of a variety of different symptoms. And we're going to talk about what each of these symptoms are, whether it's the illusions or the hallucinations or the delusions. But somebody who really is going to experience problems, or if we see somebody who's really experiencing some severe problems with hallucinations, this is often sort of the story in terms of how it progresses. It may start with just some mild illusions, kind of thinking that something might have been there, but not really there, and then eventually that transforms into well-formed hallucinations where there's actually a figure and kind of a distinct shape that they can talk about. Usually when this starts, patients are able to retain a certain degree of insight and can kind of recognize those really are not real. But at some point that insight is lost, and that's when things get really challenging in terms of being able to manage it. And then eventually if those progress, then patients can start developing delusions. And so it can kind of progress from this very mild thing to this more complex thing. And that's why I think it's important to be able to recognize what's happening earlier on and to really kind of address the risk factors and take what action might be necessary. Now, another reason that hallucinations are very concerning is that they tend to be one of the strongest predictor of nursing home placement in patients with Parkinson's disease. Okay, and I'm not saying this to scare anybody, but just this is the reality. So if you look at individuals who have been admitted to a nursing home who have Parkinson's disease, they tend to be older. They tend to have had Parkinson's for a longer period of time. They may be more advanced, and those are kind of things that maybe make sense. The care demands kind of increase, and so it may become more challenging to take care of those individuals at home. They have more impairment of their daily living activities. They're maybe more cognitively impaired. Sometimes in some situations when they're living alone and these are happening, that will often increase the risk or the chance of nursing home placement. But then also on this list is the hallucinations. Okay, and I think that part of this relates to just sort of the difficulty in managing them when you also have the other features going on with the physical limitations and the cognitive limitations and the behavior changes and things like that. But if you look at each of those different factors and try to tease out which ones are maybe most prominent, the ones that are listed on the right-hand side of the slide are the independent predictors of nursing home placement, and hallucinations does fall under that. And I think that's, just to highlight that this is an important issue, and the fact that we're going to talk about towards the end, which is that there are ways to address this and to treat it, so hopefully these are situations that can be avoided. All right, so let's move into a few definitions here. So we'll talk about each of these different items. So obviously hallucinations, we'll talk about delusions and paranoia, we'll talk about illusions, and then we'll talk about a few other conditions that are sometimes often confused with psychotic symptoms. Okay, so sundowning, for example, or delirium, or the REM behavior disorder, which are really not in the group of symptoms that we would typically consider to be psychotic features. So what is a hallucination? A hallucination is when someone sees, hears, or feels something that is not actually there. Okay, so if somebody, your loved one, is talking about something that they might be seeing, or maybe they have a sensation or something and you are not actually experiencing that, then we have a suspicion that that could be a hallucination. The important part about this is that it occurs when the patient is awake. Okay, so anything that's happening at night during dreams or while the patient is asleep, that might be a dream or a nightmare, or as we'll explain, maybe even a component of this REM behavior disorder, but that is not a hallucination. Okay, patients have to be awake. Doesn't mean it has to be during the day, they just have to be awake. Okay. Hallucinations may be more likely to occur in situations of low light or in low visibility. So we talked about individuals who have vision impairment, but then also in the evening, for whatever reason, that may be more likely to trigger these visual illusions that patients can misinterpret and actually start reacting to. Now, the estimates that you will see about the prevalence of hallucinations vary kind of all over the place, and I think part of that likely relates to just the way that people ask that question. So some studies and some materials that you might see might suggest that upwards of 50% of patients have ever had a hallucination, and that might be true, that ever having had a hallucination is probably a large proportion of Parkinson's patients. But probably the degree to which something really needs to be done about it is a lot less. Okay, and so that's why you're seeing here on my slide the figure of 20 to 30%. Okay. Now, what are some examples of hallucinations? So there are several different kinds of hallucinations. The most common one is visual hallucination. So visual hallucination is the part where a person is seeing something that nobody else sees. Now, in Parkinson's, these are the most common type. Common themes include seeing animals or bugs or people. I have had several patients where they will see maybe a person out in the backyard or maybe somebody sitting on the sofa. It might not be anybody that they know. It might be a deceased family member. There could be several different forms to this, and there's really not a whole lot of rhyme or reason to why it might be one thing or another, but that is a common one. Bugs are another one, and it could be bugs crawling on the floor, it could be on the wall. One of the most severe cases that I saw was an individual who was convinced that there were bugs crawling out of the food and so didn't want to eat anymore. So these things can take a very broad range in terms of the severity, okay? And how we approach them may depend on exactly what the features are and how prominent they are. Auditory hallucinations are when an individual hears voices or sounds that are not real. So they're talking about hearing voices or hearing a sound, and you have not heard that in the same, kind of time period. So examples here are maybe music playing in the background, maybe a baby crying, or maybe water dripping was another one that I had one of my patients tell me about. So she was convinced that the faucet was leaking because she heard the dripping, and so then the family member had to come in and they had to take everything apart and sort of prove and show that really there wasn't anything going on. So these are some different aspects of it. Olfactory hallucinations are when an individual smells an odor that is not really related to an actual source, and these are rare. In Parkinson's, I can't think of a patient where I was convinced that they were having an olfactory hallucination. There is a type of hallucination called a tactile hallucination where somebody feels maybe bugs crawling on the skin. I've had one or two patients that were convinced about that. This sometimes can be a little difficult to tease out. There might be other sensations that patients are experiencing and maybe just describing in this way. An example might be something like restless legs, where a patient feels kind of that creepy crawly thing in their legs and they feel that urge to move. And that's not a hallucination, that's actually a separate condition, but that may overlap a little bit in the description, and it's important to kind of assign that to the appropriate condition. Gustatory hallucinations are those where patients might sense an abnormal taste in their mouth that doesn't have a particular source. And again, I think that's also very rare. I have not had a patient in my practice who has complained about those types of hallucinations. So those are examples of hallucinations, again, visual ones being the most common. There's another kind of category of psychotic symptoms that are what we call delusions. Okay, so what are delusions? Delusions are illogical, irrational, or dysfunctional views, maybe persistent thoughts that are not based in reality. Okay, and so then sometimes it becomes a question of whose reality do you believe? But if there is sort of this persistent, thought process that's going on, and I'll talk about examples in a minute, that are very fixed and are not the type of thing that you can sort of rationalize that individual out of, then it might be a delusion. These are not deliberate, meaning that they're not necessarily formed in, there might not be like a true basis, and so you don't want to necessarily, I think this is hard. Okay, so first of all, delusions are very hard for caregivers to be able to deal with, because they can have kind of that accusatory nature. There sometimes is that feeling that the reason this person is saying that is because they really believe X, Y, or Z. Okay, and so you have to really take a step back and understand this is the brain doing this to the patient. It's not necessarily the way that they truly feel about what is going on. And that's, I think, a situation that kind of leads to a lot of conflict. And so it's important to kind of take that step back and recognize it for what it is. Now, sometimes these delusions can be so real to the patient that they can be even threatening. Patients can become argumentative, they can be aggressive, agitated, maybe even unsafe because of the way that they're reacting to these thought processes. And so it's important to kind of get these or be aware of these early on so we can try to address them medically if necessary. And fortunately, delusions are not terribly common. I think 8% maybe sounds very common, but it is something that is recognized in Parkinson's patients, but fortunately, not as common as things like the hallucinations. So what are some examples? I think by far the most common delusion that I hear about is the jealousy and infidelity one. Okay, so again, very important not to take this personally. I think it's hard to do, but it's important not to do that. The patient often in this situation will believe that the partner is being unfaithful, and it may be sort of a repetitive thought process that is expressed, or it may be something to the extent that the individual is taking a lot of action in order to mitigate this concern. So, for example, I have, patients and their spouses where it's really just a conversation, a recurring conversation that happens, and, maybe it's slightly accusatory, but it's more like, well, why were you talking to that person? You must be having an affair kind of thing. But not necessarily more, what do I want to say, not more aggressive than that, versus others where, again, this is a spectrum of symptoms that we're talking about, where the individual was so convinced that this was going on that they started installing video cameras and were trying to find ways to prove that this was going on. Okay, so you can understand how this creates potentially a lot of conflict for individuals. So then there is the type of delusion that is classified as persecutory. And so here the patient believes that he or she is being attacked or harassed, cheated, conspired against in some way. Again, this can take several different forms. I've had some patients who have become convinced that their caregiver was trying to poison them and so would not accept medications from the caregiver in order to take them, or wouldn't take the pills because they thought they were poison, some kind of poison or not really the medication that they needed. I've had patients who were convinced that neighbors were engaging in certain activity. Maybe they were spying on them. Maybe they were trying to do something to them. And so again, if the reality is that these are not really happening, this is where it kind of becomes hard. You have to get some confirmation of what's really going on. Then, this can turn into something difficult for patients and caregivers to handle. So patients may become paranoid, suspicious, agitated, aggressive. They maybe even socially withdraw. They don't want to go out and do things or be around because they're afraid that certain things might happen or that people are trying to do things to them. The third type of delusion is somatic, and here is where the patient believes his or her body functions or body is functioning in an abnormal manner or has an unusual obsession with their body or their health. And I'll tell you two examples. One, I had a patient who was just very sort of convinced that there were bugs crawling in his skin, and it got to the point where he was bringing in samples of things for me to look at. And we realized then that this was, so he brought these things in, there was nothing there was no bugs, there was no abnormality, but we realized that this was related to one of the medications that he was taking, and when we stopped that medication, these things markedly improved. Had another patient who was very convinced about constipation and very sort of having this very fixed delusion about the constipation symptom and very perseverating on this for hours and doing all kinds of routines and things to try to mitigate constipation. And so that became evident that it was more of a delusion rather than kind of a reality of having severe symptoms. So again, it can take many different forms and can lead to a lot of different behavioral challenges for caring for these individuals. All right, so those are kind of the heavy ones. We can move on to some lighter ones. Illusions are having sort of a sensory misperception in which the patient misinterprets real things in the environments. And so these things may not be as scary or as burdensome or as cumbersome. So you see the example here. Who sees the face in the... Anybody see the face in the mountain here? Okay. Yeah, so, some are more likely. Anybody could misinterpret something like that, right? So those don't necessarily have to be, harbingers of bad things or indicators that hallucinations and delusions are going to happen. Examples in Parkinson's patients might be that the clothes in the closet look like they might be a group of people. So you're not really seeing the person, but it's just that sense that those clothes are there because there's people there. And again, these similarly occur in low light or low visibility situations, and they can be, as we talked about with the hallucinations, also aggravated by certain medications. And so, again, it's important to recognize when they're occurring so we can take appropriate action. Sundowning is different again. So this is restlessness, agitation, irritability, confusion that can begin or worsen as daylight begins to fade. And so these again are more likely to happen in situations of low light visibility. Patients may have very stark behavioral changes that occur during this time period. They may even actually hallucinate during this time versus not during other times of the day or the evening. But one thing that's consistent or particular about sundowning is that it tends to be predictable and it tends to have a consistent time of onset, and it's usually that evening time when the light's kind of going low. And these symptoms are more common when dementia is present, but again, sundowning is a little bit different from kind of that hallucination, delusion type conversation that we were having earlier. Delirium is another one to be aware of. This is a reversible change in a person's level of attention and concentration, okay? And that is something that usually evolves fairly quickly, maybe in a matter of days, sometimes in a short couple of weeks. And patients may be very lucid, but then maybe very out of it and kind of talking out of their head and talking about seeing things and things that aren't really happening. But there's usually this sort of alteration in kind of their level of awareness and their ability to kind of appropriately identify what's going on in their environment. So very disorganized, sometimes the unusual behaviors and hallucinations. And one of the things about delirium is that this very often happens in the hospital setting. And this is one of the main reasons that I really dislike having my Parkinson's patients in the hospital, because this is so likely to happen. It's very common. So if you're in for a medical admission or maybe even just for a procedure or a surgery, you're in an environment that's new, that's different. People are poking, they're prodding, you're not getting your medications on time, you're not sleeping on a regular schedule. There might be electrolyte disturbances, all these other things that can just, in the right environment, really aggravate the cognitive status of a patient and cause this, very, very prominent change in their symptoms. And this is problematic because it tends to prolong the hospitalization. Patients with these delirium type symptoms end up often going to rehab facilities after sort of what should have been a minor kind of hospitalization or stay, and in some situations is really associated with a poor prognosis. So this is different. Again, you can have hallucinations or altered thinking in states of delirium, but this delirium is different from the type of thing that we would talk about if we were dealing with somebody who on a regular basis was having hallucinations or delusions. Okay, back to this REM behavior disorder quickly. REM behavior disorder is during REM sleep. Normally, everybody here has REM sleep and everybody dreams during REM sleep, but when people who are unaffected with Parkinson's have dreams, they dream quietly and they don't act out their behaviors. And that's just sort of the brain's way of keeping people kind of calm and getting restful sleep. But during Parkinson's, those signals are lost. And the key here is that it's happening during sleep, but patients may be very vividly reacting to whatever it is that they're dreaming about. So they have this dream reenactment behavior. And that's not a hallucination. That is a dream. It is dream reenactment and it is REM behavior disorder. They might be punching, kicking, fighting, screaming, yelling, talking, what have you. A number of different features. And so if they're waking in the middle of that, then it may seem like they're having a hallucination, but that's still very different from being wide awake and talking about seeing somebody that isn't there or a bug or an animal or something like that. Okay, so just very important to distinguish that nighttime dream reenactment behavior from actual hallucination because they're not the same thing. To get back to the question about is it Lewy body dementia, I'll just reiterate, just because somebody has hallucinations doesn't mean they have dementia and doesn't mean that they have Lewy body dementia, although these are things that we would want to evaluate to make sure that that's not sort of the process that people are going through. But Lewy body dementia is when the cognitive changes and the Parkinsonism start at the same time or in close association with each other, and hallucinations can be a very early and prominent feature of that. And so can the REM behavior disorder, okay, as we talked about. But these patients have a very different kind of course. It would have been something that started at the beginning, not something that came later. Okay, so that's kind of the key difference. So what do you talk to your doctor about? So I think first and foremost, we talked about all these different symptoms. I've heard people coming in and mentioning all of them and maybe using the terms incorrectly. And so you can understand how that might lead down kind of an incorrect pathway of management if that was not really the situation. So first and foremost, just confirming that the symptoms that you're concerned about are hallucinations or delusions. Then discussing really the frequency of these, the timing of them, the severity of them, whether or not the patient is retaining insight into it, whether or not there's an associated behavior change. These are all factors that we would think about in terms of deciding how to manage it. So causes of these hallucinations could be things like medications, both the medicines that we're using to treat the Parkinson's, as we talked about, but there can be other medications that can contribute as well. The progressive brain changes of Parkinson's can make people more prone to the hallucinations, so sometimes we just have to accept that that's part of the disease. We do often want to make sure that there aren't other medical conditions that are contributing to the problem, and one of the most frequent ones is something like a urinary tract infection or another type of infection, because these are just sort of very rapid changes that can happen and can provoke that. And usually if there's kind of if it's happening sort of at the flip of a switch, this is one of the things that we want to be sure to rule out. And then as far as other medications that might be contributing, I think common ones that we have seen are things like pain medications, including narcotics, certain antibiotics, steroids, sedatives and tranquilizers, and in rare cases where there might be ongoing drug or alcohol use, then those things need to be addressed as well. And then lastly, if we're kind of looking at all of these things and we're seeing kind of that progression, then we might be concerned about Lewy body dementia. Oh, good gracious. Okay, I've been talking way too much. Okay, so behavior management. This is probably maybe one of the most important slides to go through here. Not all hallucinations need to be treated or addressed. Sometimes it's okay to just kind of go along with it. I would not advocate trying to argue patients out of the hallucinations or reasoning with them. Again, just understand that this is a phenomenon that's occurring as a result of brain changes. The brain is doing this, and as a lot of times patients, if they're not retaining the insight, it's going to be very hard to try to convince them that this is not reality. And again, I've seen a lot of conflict between caregivers and patients because they're trying to convince the patient that, no, that's not real. Stop telling me you're seeing that person isn't there. Let it be, okay? And just kind of go along with it. Nod your head, say, yes, that's, interesting, or, maybe we can talk to that person another time, or find another way to kind of mitigate it. Sometimes refocusing the patient's attention to something else will allow the attention to that particular issue dissipate. Trying to find workarounds for it. Okay, maybe that's going on, but let's talk about what we did, some other time, or some other event, or some other activity. Sometimes maneuvers like turning on a light or shining a flashlight can help sort of show that there really isn't anything there, and for some patients that might be helpful in dissipating the actual hallucination. But if you're really noticing that significant or persistent behavioral change, that's really something we need to discuss with the medical team. So if you do that, things to look at are what's going on with the Parkinson's medications. And usually in situations like this, I like to keep it simple. And levodopa is kind of your friend in this situation because most of the other medications have a much higher risk of aggravating the hallucination. So if I have the opportunity to minimize a dopamine agonist medicine like pramipexole or ropinirole or rotigotine or any of those dopamine agonists, also amantadine is commonly likely to provoke hallucinations, so I try to get rid of those, peel those away, and really just kind of keep it simple. And sometimes that's easier said than done, but in the end, if you can minimize the different factors that are contributing, then that can be very helpful. And then certainly checking the other medications, like are there pain medicines, are there other neurologic or psychiatric medicines, recent changes like antibiotics or other things that might have contributed, you can clean that up a little bit. And if we need to manage it medically, then we do need to be careful. There are the antipsychotics that we talked about, but those are risky in patients with Parkinson's because you can imagine that if we talked about needing the dopamine to be able to move. If you block the dopamine or if you don't have enough dopamine, then you have symptoms of Parkinson's. So if you then go give an antipsychotic that blocks dopamine on top of that, then it can actually make the Parkinson's worse. Okay, so we have to be very careful. There's 2 antipsychotics that are relatively safe to use. One is called quetiapine or Seroquel. The other one is called clozapine or Clozaril. And each of these is not as strong of a dopamine blocker, and they can be used relatively safely in treating Parkinson's hallucinations if needed, but they do have other issues. So, for example, quetiapine can really make people sleepy. It can affect the blood pressure. Clozapine can suppress the white blood cell count. So they're not always favorable. And so thankfully, we have another medication, one that's been approved more recently called pimavanserin that does not block dopamine and which works more on serotonin receptors. And so the risk of aggravating the Parkinsonism is not there. This type of medication doesn't typically make people sleepy, and so we can use it often very successfully in treating Parkinson's hallucinations. And so this may be something to talk to your physicians about. All right, so in conclusion, correctly identifying hallucinations, I think, is the first step in all of this, because again, there's a number of different symptoms that can sometimes seem like hallucinations but aren't not the exact case, so make sure that that's really what you're dealing with. Identifying and addressing any of the contributing factors, simplifying the Parkinson's regimen, trying to address the behavior part of it, meaning your own behavior as well as the patient's behavior, and trying to accept and work with the hallucinations as opposed to trying to convince them that they're not real. And that may be warranted and can actually be even quite successful before the need for medication management, but the meds are there if they're necessary.